and really also support the local production of these tools so that there is some benchmark that developers can use and work off of to inherently support service delivery rather than data collection. So there's really a need for guidance for technology developers like yourself to ensure the quality of these digital health solutions. And I think what we've seen globally is that ministries of health or health program managers kind of they get an application in front of them, it looks great, but it's really difficult to scale. It's not interoperable. There's dependent on a single vendor. It becomes a black box, and so there's a need to ensure that the technology partners and the ministries of health have a shared language to ensure that they know exactly what's going into the digital systems that are being used by their health workers, and to ensure that the systems are designed in this human-centered way. And also so that you're also confident that the decision support logic that you're encoding into the systems actually doesn't end up hurting anyone, right? Because I don't think anyone wants that. And so we have the smart guidance work to really try and address this key issue and ensure that this partnership between the health program leads and the digital health leads are really hand in hand. So when we think about digital health implementation, the way that WHO thinks about it is that there's three key components. So one is the health content, so what should actually be the health information that's in it, what data needs to be collected based on recommended best practices. The actual digital health intervention, so what the system needs to do. Does it need to provide decision support? Does it need to provide reminders? Does it need to provide scheduling, anything, those kind of discrete functionalities, and then the actual service and application. So there's a channel in which those content and functionality are combined to then deliver the content. And so what we see is that really the health content, the intervention should be determined by the program managers, and then it's the job of the developers in the room to then provide this digital service and application based on the requirements that are outlined by the program managers. And so the smart guides are intended to intervene at the gathering user requirement stage and the design, adaptation, development stage of the software development lifecycle to ensure that the content that you're working off of is really informed by evidence-based practice and also informed by WHO recommendations. And so we have this 5-layer framework that we use to think about what the smart guides are. So first is the narrative layer. So this is the content that WHO publishes normally already when it comes to policy documentation. And this is used to inform the health program managers how to actually change policies, implement programs, implement interventions, and actually guide the direction in which their digital solutions should be deployed. But then we then want to translate this content into essentially a requirements documentation, and we call it a digital adaptation kit. I'll go into a bit more what that contains to really take this content that's in narrative format and distill it into these concrete parts that are more easily understood by technology partners who are not necessarily health program managers, public health people, or clinicians. So then we take that and then translate that into the machine readable content, so the FHIR implementation guide, which you'll hear a lot more about from others much smarter than me, so I'll leave that to them. And then we take these machine readable content that is based on the FHIR standard to then create these executable components. And so I think I want to just emphasize that the L4 isn't intended just to be an app you can download off of the App Store, but really these software components that you use can build off of. And then forward-looking, we look to hope to actually inform the guidance that WHO develops based on information that's collected at the point of care in country, using advanced analytics and AI to really inform that, because the way in which clinical guidance is developed right now is based on systematic reviews and expert panels. And so we want to supplement that with additional information that can actually be collected through digital systems that countries are using. So the components of the digital adaptation kit contain, there are 9 key components. I think just to flag the previous digital adaptation kits that you might have seen have been 8 components, but that's because we just split out the decision support logic into decision support logic and scheduling logic. But essentially we have the health intervention recommendations, so really outlining the scope of the digital technology, who the personas are, what the user scenarios are, what the key workflows for that scope of work is, the core data elements mapped to semantic standards, decision support logic, scheduling logic, indicators and monitoring, and then functional and non-functional requirements. And we leverage existing standards for business analysts and business process documentation, such as BPMN and DMN, so business process modeling notation and decision modeling notation. And I do want to highlight, though, that this doesn't take away the need for human-centered design in any way. So the generic personas and user scenarios are just based on what the assumptions that have gone in for informing WHO recommendations, but when you actually build a system, you still need to go into the health facility, talk to the health workers, and understand exactly what their needs are. And so just an example of what this looks like for immunizations is that we have the immunization recommendation tables, as guidance for immunization program managers, and there's actually about 10, 12 more documents that the immunizations programs actually publishes for their program managers to manage an EPI program. We then take that into this digital adaptation kit, so we have mapped out the workflows, the decision support logic for the immunization schedules, and the scheduling logic based on that. And then we have translated that into the machine-readable content. And then there's an executable version that some developers in this room who can probably speak more to it as well have developed. And then forward-looking, we hope to see that this could be used for precision public health for vaccine-preventable diseases in the future. So the scenarios of use that we see is that it really provides a shared language. So the content in itself is, of course, helpful and important, but each country will have their own policies, have their own context. And so it's really more of a starting point where they can work off of, but it's actually the process in which we hope to encourage countries adopt, to have every country have their own version of the SMART guideline, essentially, because it allows for a benchmark for governance and compliance for digital solutions that are deployed in countries, and also ensuring there are reduced time and resources that go into development. And of course, if countries already have systems in place, they also provide a way and a pathway to understand how to move towards interoperability standards, and then being able to update content that maybe aren't ready to go digital yet, even seeing what paper registers can be updated based on the concept and idea that they want to eventually go to digital. And so the grander picture of this is how maybe you have heard Carl present this earlier in this 3 days, is that the SMART guidelines are really an enabler that we see to move towards a personal health record. So the idea is that each country will have their own software system. So this is an example for like an electronic immunization registry or home-based record that adheres to the SMART guideline standards. And they have their own certificate issuance software that they can use based on, again, the SMART guideline standards. But then the actual certificate itself could be in a paper printout, a PDF, or an app, or just a card. It just depends on the context in which these technologies are deployed. And then that information can be bilaterally verified across member states using a federated global digital health certification network, which is what WHO had launched last year for verification of health documents. And so, again, just to emphasize that the digital adaptation kits and the SMART guidelines overall are really just one piece of the puzzle when it comes to digital development for countries. And so the idea of human-centered design is really critical here, and we have another guidance document around that. So Digital Transformation Handbook for Primary Healthcare. I think there are several copies available earlier in this week, but that was basically to ensure that these things work together. And then, of course, from a grander scale, to note that countries are also going to be need to be looking at how to actually plan digital implementations from an architectural perspective overall. And these digital adaptation kits and the SMART guidelines are really just the one determining health content requirements component of the entire ecosystem of digital development. So with that, I'll hand over to my colleague Jose to go into a bit more of the technical details around this.
Thank you. Yeah, so let's see how we are using this from a technology perspective. So what are the technologies that we are using, how we are using them, and how that makes the whole vision of easier production, deployment, and adaptation of this important content to our existing systems or to designing new systems while keeping our national architectures still under control. So the first thing is, how does this look like? So we know that we have several systems out there, forgive me, and the idea is that instead of several silos of information, and when I say silo of information, it can be one system that does one function, or a whole national architecture that was designed to be just using for those specific use cases, and it's really hard to maintain. I'm sure many of us have seen that a system is really big, and as systems get really big, they become more and more difficult to maintain or to add functionalities. So when we talk about silos, sometimes we can talk about very broad silos, but still a silo. It's really hard to add new things. We want to add using standards, and having smart guidelines as a standard way to use standards. We want to have to create a more flexible architecture so that systems can add functionality and adding by adding those standards. Sorry. First thing is, why do we use standards? Why do we use standard content? The first reason for that is that because we do want to use standards to express data in a consistent way, that's what we want. I mean, we all know that it's easier to make a custom interface between two systems because who cares? This data is not going anywhere. But first thing, preference to use standard data because we want to use standards, because we know we want data to be reusable. We want data to be to be used in primary purposes and secondary purposes. It's another microphone. Sorry, just got an echo. The other reason for us to use standards is not about only how an existing system communicates with each other, with another one, is that having structured machine-readable content, which what FHIR allows us, we can actually have all this process and all this content that Nat was showing, this actually becomes something that we can use at scale. So we can make all these smart guidelines, we can create a lot of those, and those types of content, those rules, they become easier to maintain, easier to transport to the country. So a bit addressing the problem of this taking too long to implement. If these things become machine readable, then we have a chance at having tooling. Then we have a chance at having procedures for that. That's what I'm going to describe the advantages of this. So if we have a part of the smart guidelines, so all these, I think all the images that I'm using here, they are from the Smart Guidelines Starter Kit, which is the SOPs for the smart guidelines. So it's out there. I don't think I put the link there, but all of these diagrams are there. There's a standard way of using the FHIR content in smart guidelines. Whatever we do in the smart guidelines, we try to express this as standard resources. So Nat was mentioning not only FHIR, but for example, BPMN, we have DMN. So those are standards that we use to author content. We know it's easier to use custom solutions, make a fancy app to enter data or to design data, make a nice looking document, but if it's standard, then we have a much better chance of having this processable by the tooling. I'll get to that. But basically the last sentence there, when we have this kind of structure, we can industrialize. So the key point is we want to industrialize the production and the usage of these guidelines, of this content. What is the kind of content that we're talking about? So Nat was pointing at the L2, the structured content. This is what SMEs do. This is what clinical experts, they decide that in countries with high risk of measles, the children should get vaccinated as of 9 months. In countries with a lesser risk, then children should get vaccinated as they turn 1 year old. These are the kind of rules. So these are rules that are relatively clear to understand. They are not machine readable yet, but they are clear to understand. And we have also, so we have several rules. We have, for example, definitions of indicators. How do you monitor the number of vaccinated or unvaccinated people? Those are precise or well-defined indicators. In the L2 and in the smart guidelines, we structure these things as data objects. So we say, what is the container? How do we define an indicator? How do we define a health intervention, a user scenario, a persona? All of these are the required elements in the L2. And in the smart guidelines, we say, good, now we capture this in templates, in existing stable infrastructure so that we can then have different authors contributing to this. We can have tooling doing some of the work for us. And these are the elements that we have in the L2. So the L2 is structured and it's, let's say, templated so that we allow different people to author the content. We allow two collaborators to review each other's work. And that is part of the L2 guidelines. The L3 is more interesting, of course. The L3 contains the technical content. This is where a technical author, or in my view, definitely more than one technical author, have to contribute to collaborate and take the L2 content and create all those FHIR resources. So we use FHIR resources for all this machine-readable content because it's an open standard, because of all the reasons that you have. There's another reason there. But having this as fire resources, that's our starting point. And we create from all of the other L2 elements, through predefined procedures, we come up with logical models, profiles, questionnaires, value sets, code systems, libraries that contain the plan definitions and the measures. We have the activity definitions as an additional thing. So on the right side of that diagram, I would say, besides the value set and code system, we have the actual implementable and executable thing. On this side, they are more for documentation. So on the left side, we see scenarios, requirements, test plans, active definitions. Those are things that are important for us to maintain the specification. The rest is how the guidelines will actually be executed. Let me give an example. So yeah, if I define that single definition of if a child has this age, should be vaccinated or not, the work of an L3 author is to read that and create the plan definition that's going to contain the activity definitions, which is going to be used in a library and will be using logical models and profiles to express that thing. So this is the authoring process. All of this is, I hope, relatively well documented in the SOPs. So we have provided not only the guidance of use this fire content to represent the guidelines, we also say this is how you should do it. I'll get to that in a second. But these are the technical artifacts that people are expected to produce. And if everyone produces these things, then we have indeed a better chance at industrialization. We can have more people contributing to this. Before I go, on this thing. So if we have different authors, if we have a technical author doing the profiles, another technical author doing the CQL code, and another author doing the logical models, and another one using the structure maps for data extraction, this is a lot of work to be done. We have experienced that it's a lot of work to be done. And it's really hard for one single person to do all of that and have someone peer review that. It's really difficult. It's really a lot of content. So one of the things is that if by structuring this content, we actually start saying, how many plan definitions do we have? Do we have any duplicate ones? Do we have libraries that are duplicating the content? Do we have questionnaires? How are we with the questionnaires? So we start having some structure, then we can actually have some roles. So for those of you that have been joining some of the capacity building discussions, one of the things is that if you are an L3 author, you have to do really a lot on the smart guidelines. And some people have painful experience with that. So we want to say, maybe if you want to focus, or if you don't need all the things, or if there's some things that you want to put on hold, for example, the structure maps for questionnaire extraction, they are not normative. So maybe you leave that to whenever you have that kind of resources at hand. So we also want to articulate this kind of authoring content with the roles that are needed and the rules that are needed for that. So if we have a chance also at separating and allowing some specialization of the roles. So basically a short description of this. So everything can be cataloged. So we will have a list of all the data models, all the profiles, all the value sets that are used. And now I'm entering the stage of the question of, it's not about one person or two people authoring one implementation guide. It's about 2 people, 3 people, 5 people over the course of 5 years implementing this in a country, maintaining this, whether the WHO changes the guidelines or the country changes the implementation preferences or directives. It's about maintaining this at scale. It's not about authoring one. Authoring one for us tech geeks, it's easy. It's the easiest part. Making it in a way that other people can review it, that other people can co-author, and in a consistent way, that is a tricky part. And that's what I'm going to check after this introduction to how the CQL is created. Has anyone here looked at CQL code recently? Or not recently? Like, would have been recently. Some people. Has the others, have you heard CQL? Have you heard about CQL? Hands raised, please. Okay, most people. That's good. So I guess that people are hearing about this, but not doing CQL, not looking into it yet. So while I'm not the expert in CQL, and it's intimidating because I have the experts over there. The CQL basically is a abstract language to define data definitions. Basically, you can say that, here's an example there. So if you want to say, so the rule for the smart guidelines is if no measles primary series dose were administered and the client's age is more than or equal to 9 months, then do something. That is what the clinical expert does. They define these rules, and they can even facilitate with some pseudocode or some pseudo definitions underneath. That's what the smart guidelines procedure says. You define those things and try to add some pseudocode. But that's as much as they can go into. A clinical expert does not talk fire, should not be forced to understand fire. They know these things very well. They can express these things very well. Then someone has to go and say, okay, let me try to transform this into an actual code that then I can run somewhere in my system. So what CQL does is to say, oh, how do we define the no doses administered? Well, this is if the number, so the first definition is if the number of doses administered is 0, then the no MCV doses administered is true. So basically that's the definition. But each of these definitions, they relate to each other. So if we have, so these are the third and fourth, they are the client age. And as you can see, so age in months at today, so that's another function. So each function, and there's a graph that I'll show next, each function, each definition depends on other definitions. So what I'm saying is that each client's age is more than or equal to 9 months. That's one definition, it's true or false. And that depends on the age, but the age I'll get from somewhere. So I'm making definitions on top of definitions on top of definitions. So CQL is pretty much a language where you define data elements from existing data elements from existing data elements. And those turtles go all the way down to the point that you can say, and I get this from the fire patient resource, or from the fire observation resource, or from the fire condition resource. So one of these definitions eventually, I don't have it there, will get to the fire patient resource. So if you have those definitions to say, this is how you define the patient being equal, the age being equal to 9 months or more, eventually that will come from a patient resource. That is what the CQL authors have to do. It's a lot of work. All of this goes into a library resource. It just has some hashing thing because, or some base64 encoding because it needs to be transportable in JSON, and then this is what we use in plan definition and activity definition. So the file resources, they play a role by saying, you author the code, you contain them in a library, which is then used, and saying the step is, the patient goes into the clinic, first thing to do is check if the patient needs to be vaccinated for the measles vaccine first dose. How do you do this? Here's the logic. That is what the smart guidelines say about decision logic. I have a question there.
Thanks, Jose. It's nice to see you. My question here is this. Is there the expectation that given the guidelines that already exist in WHO that have been written will be transformed and libraries created for those where without people having to then redo the analysis, they can just consume the library?
The answer is yes. We want these things to be reusable, machine-readable content. We want developers to just say, oh, I don't have to redefine all these in very big level, many levels of definition of things until I get to the file resource. Actually, we want that prepackaged and canned, because if we don't have that, everyone will recreate their own thing. So we have discussions in the authoring community, we have discussions, a lot of discussions on, I use this resource, but is it the right one? And the moment that any one of us has this question, this means that every single one will have different ideas on how to implement this, which brings us to non-standardization, which brings us to problems, which brings us to maybe wrong decision, the support that's being given, which means that the indicators will be skewed, will be biased anyway, because people have done this differently. That's one of the biggest problems, and that's why we want to industrialize this. Not only the content, but also the processes.
Just to add a caveat on that, because I think the reality of clinical guidance in general is still quite vague in some areas. So although as WHO we're trying to create these components for all of primary healthcare, there's still that critical factor of countries having to ensure that their policies are contextualized and specific enough. and then the L3 would then subsequently need to also be adapted as well. So it's not as easy as just taking it off GitHub and then like plugging it into your code base. There still needs to be the process of going through the requirements with the country and then making sure those requirements and changes to the digital adaptation kit are then reflected in the L3 content as well. So it's, yeah, just want to comment.
Thank you. That's an important topic, and indeed, it should not be seen as WHO will tell the country exactly what the national guidelines would be. This is the starting point, but if you have different data definitions, then there is a process for adapting this. Another show of hands. Who here is looking at this to adapt to their countries? And I expect 90% of the hands raised. Who here is looking at this to adapt to their countries? Smart guidelines as something that needs to be adapted to the countries. I expected 90% of the hands raised. So some people, sorry? Yeah. Developers, oh, but I include like who here is going to develop or is thinking that they will develop these things in their country, not at global scale. I think not many people will be doing this for a global scale. Most people will be working on doing this at national scale, right? Okay, let's take that as my impression of the 90%. Let me think of that. So if we have this process of adoption, let me start first with adoption, and I'll get to the adaptation later. The adoption process means that we will use existing code. Now, this is a very small part of the CQL code for the immunizations IG. I just did a small, like, how does this code look like? Because definitions can point to definitions, which is really weird if you have to look at very easily thousands of or tens of thousands of lines of code. No one looks at tens of thousands of lines of code, and no one wants to write tens of thousands of lines of code unless with the deliberate purpose of no one ever figuring out what's wrong. So many lines might be repeated because that's what we do. We code things and sometimes we forget to delete the things that are irrelevant there. These are operational problems from development. So we have those separated into libraries. This comes from the guidance that we have from CQL and from the existing approach on FHIR on this. These things are split into libraries. For example, there is the commons, there is the WHO common, and then there is the FHIR library. So we have different libraries, each of them providing a layer of those definitions, and they depend on each other. But each of them may be adapted. So let's talk a bit about adaptation. So I want to use the SMART guidelines for immunization, and that says that, yeah, if a child is older than 9 months old, then I should give immunization. But I live in a country where, fortunately, measles is not a high risk. So I want to change that from 9 months old to 1 year old, because that's what the guidelines also say. And the library currently doesn't have that code. The library says if it's 9 months old, do. If it's 9 months, do. If it's less, don't do. I want to change that. So I would like to change just that level. I don't want to change all the single things that says, oh, how is the age going to be obtained? It's still from the patient resource. I don't need to change the fact that the age is going to be obtained by the patient resource. What I need to do to change is those equations, those conditions over there. So the more than 6, less than 9. This is why we have things in layers, so that people can also do a bit of that. The authoring process that we have in the SOPs, it pretty much goes through all these artifacts there and says, this is how you author one of these things. You look at this, you create the code, you create the library, etc. So if we have this kind of complication there in the CQL, this is really difficult to maintain. Some of us have not even dared too much into looking into it, myself. And the problem is that it's really difficult to find anyone who can review someone else's code. We know how this is already in simple coding, like in normal things that we use every day. Code review is not pleasant, is not easy. Code review of a big chunk of code of tens of thousands of lines from someone that thinks differently than you is really impossible. So how can we have some sanity in that review process? That's when we have when we enter with industrialization. So how can we take all these challenges? Like, countries will have different requirements, but they will still use the same, they should still use the same platforms, the same tools, the same way of working. Because we might not have a CQL expert in our country. We might need to borrow a CQL expert from another country. We don't have structure maps here, but we will need this for just one purpose, for just one project. So if we want to look at how can we do this at scale, we look at requirements for industrialization. So the smart guidelines, for me, they have really good content, really good structure. For me, the richest thing is that it allows us to industrialize. It allows us to create digital health systems at scale, to author those things at scale. And it's about smart guidelines, but much that you see there is transportable to doing anything else with FHIR. So what we want is outcome consistency. We want two experts to produce not two different results for the same challenge. We do want that. We do want version control. I'm in a room, I don't need to justify that. We do want roles and rules. Roles in the sense of who is going to get a CQL training, who is going to be responsible for managing the CQL code, who is going to be ensuring that all our logical models, they are somewhat consistent, that I don't define patient first name in one model and patient given name in the other model. So who's going to do that? Maybe those are different people, so we start having some roles. In some places, maybe it's the same person that does all of that. In some places, we want to split that. We do want to have templates, and we do have a lot of those. And we have two of the biggest things that we have is tooling. So once we have machine-readable content, it's not only that the FHIR servers can run the queries, is that we can have tooling that says, oh, you have this template, let me create the test cases automatically. Or you have this, let me just zip it and create the library automatically. We have that in place. Or you have this, let me just create the inventory or the catalog, the glossary of terms. Let me just create the catalog of approved versus unapproved value sets. So we have a chance at having some tooling that helps us with one of the important things, which is QA checks. So if we want to have quality, we have to define what that quality is, and I'll get to that right away. Yep.
Thank you so much. If you can just go back to that slide. Yeah, I'm Frank from Uganda, and we are at a stage where we are finalizing L2. And I like that statement of going from L2 to L3. So maybe if you can speak more about that, especially on L3 OSAS, create the necessary artifacts to cover the entire specification and demonstrate a working SMART guideline. Is a SMART working guideline the implementation guide at the end of the day, or it will be the actual working code in an application? Because that's what we want to do. If you can speak more to that statement.
The SMART guideline, from what I see it, is the content, not the code that runs the content. So we have the L3. This is so going from L2 to L3 is how do you define things, there's a diagram at the end of the presentation, that allow your systems to execute that logic. It's not those systems. Now, with that, we have on the L4 level, and I'm looking at that table to correct me if I'm wrong, on the L4 level, which is the executable part of this, then we have lots of libraries. So you don't have to create your own CQL engine. There is already a running engine there. You don't have to create your own structure map extraction tool, because there's already a reference implementation of that. But the SMART guidelines, the ones that we do globally and the ones that we do nationally, they are the content. They are the implementation guide. So if you do an L3, according to the SMART guidelines, your net outcome, your real outcome is an implementation guide with the criteria and following the process that we have for the SMART guidelines. Does that answer the question?
So L3 is the implementation guide.
Yes,
Okay, thank you. Got it.
with all that it means, huh? It's not just one vague thing, it's all the technical content. Thank you, Matt. Thank you for the question. So yeah, we want to have people authoring all this, the content, the L3 content, based on the L2 content, which can be based on the SMART guidelines L2 and or the national preferences, the national things like gender values, marital status values, if that would even, or risk professions. Those are things that will be contextualized. If you want to talk about HIV, for example, I don't know if the groups for HIV risk professions, they will be the same, maybe not, for different reasons. So those are things that will require adaptation. So, but how can different authors create that consistent content? How can I talk to two experts and expect that they will create somewhat consistent code? How can I expect myself to create the same content on Monday and on Friday, still create things in the same way? This happens to at least one of us in the room, that we cannot have, it's really hard to say, or it's really easy for us to say, what was I thinking? You know, so it's something that happens and we have to deal with it. We cannot say the rules will tell us exactly what to do to all the detail, but the rules can say, how do you check these, if there's any discrepancies that make sense or that are impactful? Can we scale out by specializing skills? Can we use those tools in automation? For example, if we have to make a lot of value sets, I don't want to bother validating each single value. There are tools for that. But if we have this purpose of consistency and machine readable, then we can have the tools for that. How can we have the peer review? And very important, can we make our specifications findable, readable, maintainable, and reusable? So the whole purpose of the SMART guidelines is to create packages that people can reuse. So if I'm in my country, the thing I want to do as well is create a package that all the software vendors can reuse. I don't want to create something that I'm happy with. I want to create something that people can reuse. How can we make these specifications findable so that that hospital, they don't start from scratch? They use the content that nationally has been defined. Those are the things that the purpose that we have when we are creating the procedures. So if you look at the SMART guidelines, and thank you for the question on going from L2 to L3, that was just 2 lines of a huge section of going from L2 to L3. On the right, there is a table of contents of the L3 SOP. The L3 SOP is the starter kit, as it is now, has guidance on how to go from L2 to L3. It's really detailed. I don't know if I have a slide on that. No. But basically it says, so for each type of artifact, so all the ones that I showed in the previous slides, like the plan definitions, the value sets, all those things, for each one of those, the SMART Guidelines Starter Kit says, this is how you create one of those. You take the L2 scheduling logic, you take the logical model from there, you take the value sets from there, and you do this. These are your expected inputs. This is the procedure. And then there's some interesting things for us to make these things manageable, which is, what's the criteria? So what do you expect to end up with? In which conditions? So there's some criteria, like if you make, I don't remember one, like, for example, value sets, they have to have a name because they have to be findable in a catalog. So if you make a value set, that's fine from development perspective, but make sure that you have a name. And we have change management. How do you change these things? We have tooling that can be used for this purpose. We have some, so we point at some examples. So as an author, I can go to the SMART Guidelines SOP, so the starter kit, and say, oh, I'm trying to do a form or a structure map. Let me check the procedure. So the procedure will be clear, and then I will see the criteria that I need to have, and I can see an example of how a good form or a good structure map looks like. So we have some examples that people that are implementing this say, oh, this is how it looks like. Again, I don't have to redefine or reinvent anything. And dependency is an issue. So we also know that there are some dependencies that are not met, some issues that we're still resolving in the FHIR community or in the CQL community, and we keep a list of those. So the idea is that the developer can look at the starter kit and see how exactly can I go, what do I need to do to go from L2 to L3? This is perhaps inconvenient for one single developer in the beginning. So why should I follow procedures if I can just do things my own way? It's faster. But again, we are sacrificing that for making this maintainable, readable by others, having peer review, having these things in a catalog. So just to enforce this consistency and growth of the smart guidelines in a country. I can show a bit of the how-to of the starter kit. I have 2 more slides, so if we have time, I can show that. But the fact that we use Fire helps us not only have standard content between the systems, as we have been discussing in the architecture discussions we know how to exchange data between clinical systems, between the systems and the infrastructure, but also allows us to have so first of all, it allows us to express the L3 in a machine-readable way. So we use Fire in the L3 because Fire is an excellent way to represent all these knowledge artifacts, the value sets, the plan definitions, the libraries, all of these things are expressed in Fire. Not only because they become supported and interoperable with the tooling, but they are also maintainable. They are also versioned. They can also be put on a GitHub repository where I can get them. So there's a base advantage of using Fire for that. And also because Fire is what it's for, we can exchange data with our system. So the smart guidelines are not intended to be used in a sense of, here's a new guideline, go and make a system from scratch and populate the data from scratch. That's not the purpose. The purpose is now how do you integrate this with your system? So this is a very simplistic diagram that if you have an existing system that has some data and some rules, we can actually make the Fire interfaces for that and use the smart guidelines. So the idea is that we want to enable as much as possible the existing systems, the legacy systems or the current systems with Fire interfaces. Once we have the Fire interfaces, and I could jump now to the CQL thing. So once we have the Fire interfaces on patient data, then we know how to get the patient age. And if we know how to get the patient age, then we can calculate all those, we can run all those CQL code. That is what we want to enable. And I think the experience in Kenya has been exactly that. So how can we use Fire to take data from our existing system and run the smart guidelines on that existing data without touching that data, just finding a bridge to express that data in Fire. And the smart guidelines, they provide so there's data store for that. We have the smart guidelines, which can be the global WHO or the local smart guidelines, which will be adapted. And then we have the content, the apps and indicators, definitely, so the indicators that are going to be produced out of this. So I'm done with time. Okay. So I could, if really necessary, but I would prefer to have questions, could go into the starter kit. So there is a starter kit for the smart guidelines that show all these things quite exhaustively, and we are looking always for feedback on how to make these guidelines, the SOPs, better. As of last week, the Smart Guidelines Starter Kit also includes the L2 authoring. So key considerations for L2 authors. Basically, L2 authors have to they have to use specific spreadsheet templates because that makes the tooling efficient and the collaboration also efficient. So we have, since last week, the L2, how to create an L2 and how to create an L3 from the L2. So that's the current state of the Smart Guidelines. I hope I justify the reasons for industrialization and for collaboration because that's really the most important thing. And if we do this, and finally, by doing this with Fire and in the same way that we are working with Fire, we have the best thing that comes with Fire, which is not just the resources, but just a very rich ecosystem and an incredible community that is there to push these things forward. So once we have these things on Fire, we are entering that new way of working with things, and we open a lot of doors, and that's what Smart Guidelines are doing now. I don't know if we have questions, ideas, complaints. Sorry? No, that's it. Oh, sorry, I have one. Sorry, there was one. We will be discussing testing here, eventually there, but test is just a short remark. Thank you, Nat. So all these things need to be tested as well. So the Smart Guidelines don't expose much about testing. That's why I was almost forgetting this. But we want to have testing, and there's two types of testing that we are pushing. One of them is as you make an implementation guide, and that's why another reason for having implementation guides, there's lots of internal checks that are done automatically. So you cannot make an implementation guide if some mandatory fields are missing or if something is out of form. So you have to structure your content. So this continuous validation is one of the great things. That is out of the box that you'll get without wanting. So that's, sometimes we struggle with some of the rules, but that is exactly, we want to make sure that the content as it's published, it always is published in a good enough quality. And we are looking at ways to validate the content. So we have lots of things that allow people to validate the content. So if you have a form, we have a form previewer that allows a clinician to say, that's not what I meant something else. So we have lots of tools that are being added to the ecosystem, and we'll have more and more on testing. But one of the important parts of this is, how do we validate? So how, as I review a colleague's work, how can I do this without looking at 30, 40,000 lines of code? How can I do this without understanding FHIR? How can I validate clinically the content without doing FHIR? So there's quite some effort in making validation there, and that's all enabled by tooling. So I wanted to mention this as well.
So one quick question. So when we define like smart guidelines, I suppose at some point it needs to, like, for age example, for example, it needs to go to a FHIR resource and take, birth date, for example, right? So is a smart guideline always tied to some sort of like profile and implementation guide, meaning that like it mandates that patient resource that is going to be used with guideline has to have like birthday, for example?
Yes and no, it's in layers. So basically, if you use the standard layer, and I mean, this is something that's still open to see what's the best practice, in my opinion. But the lowest layer is from getting the data from CQL, for example, is this comes from this FHIR resource. Let's say this comes from the patient R4 resource. Oh, but my country is using R5, or my country is using something else. Then what we are saying is that we know it works for R4 if you do it like this, with these profiles, with these resources. If you do something else, then you have to go through the adaptation process. And it's still the same process. So the adaptation process, in my view, is pretty much the authoring process done again. So if all you have to change is the lowest layer of compatibility on FHIR, you're good because you have structure maps and you can do some mapping there. If, however, someone says, we don't have gender, we have gender identity, then you're in for a much more interesting challenge. But that's why we have these layers of things. So so the smart guidelines are known to work, or they're designed to work with a reference specific profile. If you change that, you're not on your own. You still have some procedures that help you adapt there.
Yes, I have a question. Thank you. My name is Fred Mutisia. I'm a medical doctor and a techie. So we've been talking as part of the Kenya Medical Association, where I'm part of the IT committee on digitizing our guidelines. We have over 100 guidelines, very fragmented. So the first question is, if let's say like you are to take HIV and you're looking at the guidelines, would you advocate for us, as starting off, we look at the minimum viable product, which is the easiest to accomplish, or do we take the whole HIV program, which has like 5 guidelines, as once in one approach? Then the other follow-up question, which came actually from a member, was for L1, the narrative guideline, how do you make it ready for the subsequent sections? Because some of them come as algorithms, some come as paragraphs, they don't have attached references. So currently, the pediatric team is working on their guidelines right now, and that's what they wanted to know. How do you make L1 ready for the subsequent sections? Thank you.
Thank you. The first question, remind me again, was?
If you have multiple guidelines in one sector,
Yep.
how do you handle it? One at a time, or do you take all of them at one go?
I think it's a matter of preference and how confident you feel that you have everything in place. And I personally would not be able to assess if I have everything in place if I did not start with one pilot. So I would say, let's see how this feels. Let's see if we have everything in place, if we have the machinery, the data, the people, the skills, let's see, or the dependencies met. Let's see if we do this. I would think it's safer to say, let's plan for the whole thing as a bigger thing, but let's not commit on estimates before we try once with one part of the program. I think that just might be safer, but that's just an opinion. It's not binding. For the second question, I will hand it over to Nat because it's a hot potato. And but I would say that in the L2 SOPs, we say at the end of this, and in the L3 as well, at the end of this, you should have this. And if you do this, that means that the next author can start.
Yeah.
So I do not know what's the status on the L1. I know it's a difficult question because technical stuff, it's easy. We can say to a developer, look, you do this, you have to have a JSON somewhere. Actually, there's a thing on naming conventions. If we have naming conventions, then everyone will know where to find things.
Yeah.
But on the clinical side, I cannot speak much, so I will leave that to Nat.
Yeah, I think you ask a really good question. And to be honest, I think the biggest challenge of adopting smart guidelines doesn't have to do with the L2 or the L3 layers at all. I mean, of course, there are challenges to that. But going through the process of even creating these artifacts revealed fundamental gaps in our science and knowledge and understanding of clinical practice. So, for example, with immunizations, we were going through the decision logic tables based on the SAGE position papers for, say, measles. And there was a very clear recommendation that you should not vaccinate a child for measles because it's a live attenuated vaccine if they're going under ART treatment until they have immune reconstitution. So it's great for a child. Well, the first question came up was, what's a child? Is it under 5? Is it under, you know? So we had to go back to our immunizations colleagues and have some sort of decision around that. And so they were able to come up with an age, essentially. But then we asked, okay, well, so what's the logic for adults then? Is it the same? They said, we have to go back to SAGE. And if anyone knows the immunizations program, SAGE is essentially the entire global governing body that looks into studies around immunizations and vaccines and effectiveness to really determine these recommendations. And so I think the question of how do we make L1 better, I think the first step is actually going through this process to understand, okay, well, what are the gaps? Because as you start to write out a decision logic table and putting the information in such a structured way, you will see the gaps in the L1, and that will help slowly inform essentially what the technical experts will have to do. But then at the same time, I do think there is a fundamental unknown that we'll have to grapple with because science, biomedical science can only move so fast. And so we are consistently working with our quality norms and standards team, for example, to make the WHO guidelines at least more precise. But the very nature of guidelines is that they sometimes are intentionally vague because there isn't a clear understanding of what you should do because the science just simply isn't there. And so as a global governing body, you can't really say, well, you should definitely do it this way, because if you don't do it that way, then something bad will happen. But then if you end up doing it that way without the clear science to support it, and something bad still happens, then of course there are a lot of problems that come with that. So, but the problem is the clinician still needs to decide. So I think these are just tools, but at the end of the day, that L1 content really is the crux of how to deliver care. And so I think going through the process will start revealing those things, but at one point it just comes down to the fact that we don't know what we don't know. So, and
It's our job, I think, to say, no, I cannot do this because this means clinical impact, this means clinical risk. So having this structured also hopefully will allow, and I'm looking for experience from the field, if you'll have this, to see how has this, in a few years, how will this have enabled a better ping pong game between the clinical authors and the technical authors that have to manage these things, because there's this fuzziness is sometimes is taken as technical people have to find solutions that are not, that are for non-technical problems, and that's also a concern for us.